2, 1. Good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida. Today we have the pleasure of having Dr. Moshe Attia, a neurosurgeon, board-certified neurosurgeon from Israel. Also, we have a couple of distinguished panelists, Dr. Luis Lopez-Ibad, MD, a neurointerventional radiologist from Madrid, Spain, and Simon Downs, a medical student from Japan. So first, I'll let the panel introduce themselves and say a little bit why they're here. And we'll start with you, Simon.
Hello, nice to meet you. My name is Simon Downs. I'm a child psychologist in Tokyo and also a medical student. I'm looking forward to the presentation.
Very good, Simon. Welcome. And Luis, welcome. Bienvenidos.
Thank you. I am Dr. Luis Lopez-Ibad from Madrid, Spain. I am neuroradiologist. I studied in last century in 1918 in Paris, 6 years with the last Professor Las Juniors and another doctor. I started neurointerventional radiology in Paris. Then I live in Madrid about 20 years ago, and I work very close to the neurosurgeon. I think that I am endovascular neurosurgeon. It's not.
It's a good definition, I guess.
Okay.
And also, Luis was kind enough to let us live stream a conference they had in Madrid, Dr. Attia. We live streamed the conference from Madrid a couple of weeks ago, directly to the internet. And so we'll come to the star of the show, Dr. Attia. Welcome, Dr. Attia.
Thank you. As you say, my name is Dr. Moshe Attia. I'm a board-certified neurosurgeon from Israel. I was trained in Israel and in the US. I did a long fellowship, a clinical fellowship in the US and in Israel. Skull-based surgery, cerebrovascular surgery, and endoscopic pituitary and skull-based surgery. Those areas actually complement each other. You do skull-based and cerebrovascular. It's very important to do both, in my opinion and in other opinions. I am serving as an attending neurosurgeon since the end of 2010. And I'm currently in Rambam Maimonides Medical Center in Haifa, Israel. And I'm very happy that you invite me to give this lecture. So today I'm going to speak about skull-based meningiomas. And in this presentation, I'm going to speak about the anterior skull-based meningiomas, and in a later on lecture, I will give a different lecture of. Do you see these slides?
Perfect.
Yes.
Perfect.
Okay, so as I told you, we will start with anterior skull-based meningiomas and lateral skull-based meningiomas. And in a different session, we will speak about posterior fossa meningiomas. So meningiomas are 15 to 20% of primary brain tumors. It's actually more common in the 5th and 6th decade. More in women. The pathology classification is according to the WHO. First, grade 1 is the benign tumor. Grade 2 is anaplastic, more aggressive tumor, more aggressive meningioma. And the grade 3 is the anaplastic or malignant meningioma. I marked here that in the last year, the publication and the literature says that there are more and more type 2 meningiomas. So it's not 4 to 7, it's even higher, it's even double. The risk factors to develop meningiomas are genetic factors like the NF2 disorder. All we know about the chromosome 22, 22nd, and the ionizing radiation therapy for malignancy, exposure to radiation. Here in Israel, we have people that were exposed to radiation in the 50s for treating tinea capitis. So we see meningiomas among them, head trauma, hormonal factors. We know about receptors in meningiomas tumors, estrogen and progesterone. We know that the incidence of meningioma is higher in patients with breast cancer and also in obesity, most probably because of the estrogen. And about the cellular use, we are not really sure, according to publication, if there is any higher risk nowadays. Changing, do you see the change of the slide?
It's okay. It's okay.
The location of the meningioma actually can be in every place that we have dura or menings. And most of the meningiomas will be in the skull base. 50% of all intracranial meningiomas will be from the skull base. And you see the most common is the sphenoid ridge or the sphenoid wing place. We have also in the Suprasellar place, clinoid, anterior clinoid, tuberculum cellar. We have olfactory groove, foramen magnum, the orbit. The clinical presentation will be because of the tumor location, because of the tumor rate of growing. Meningioma can be very, very slow growing tumor. Often can be asymptomatic, can cause headaches, focal deficits, like motor, sensory, mental status change, vision loss.
Excuse me, Dr. Attia.
Yes?
Louis, can you mute your microphone, please? I think it's causing feedback. Louis, please mute your microphone. Okay. Okay, Dr. Attia. Sorry to interrupt.
Okay. Problem with smelling, hearing loss, seizures, increased ICC. This is a skull model looking inside the cranium. You see the origin of skull-base meningiomas from the olfactory groove here, the cribriform plate, the orbital roof, the planum sphenoidale, tuberculum stella, anterior clinoid process, sphenoid ridge. You see here cavernous sinus, Mecker's cave, middle fossa floor, petrocleval meningioma, clivus, CPA meningioma, petrosa meningioma, and foramen magnum meningiomas. The diagnosis nowadays is made by doing a head CT and cerebral MRI. The imaging features of those tumors are wide dural based, hyperostosis, dural tail, calcifications, homogeneous enhancement, and pneumosinus dilatans. The confirmation, of course, is made by histology and pathology. These are some imaging of patients that I have operated upon. This is, for example, Spheno-Cavernous meningioma. You see here the wide dual base on the lateral wall of the cavernous sinus and the middle fossa floor, homogeneous enhancement. This is sphenoid wing meningioma that cause hyperostosis. You see the bone here in the sphenoid ridge. In comparison to the other side, you see it's hyperostotic. It's pathognomonic for meningioma. You see here in anterior clinoidal meningioma, it's hyperostotic anterior clinoid process with calcification. Here is an example of foramen magnum meningioma. You see here the dural tail. It's also pathognomonic for meningioma. Actually, in 50% of the cases, it can be tumor, and in 50% of the cases, it can be hyperemia. So one should resect the dura in the operation, or at least coagulate it for prevention of recurrence. This is another example of dural tail, pathognomonic for meningioma. In anterior skull-base meningioma, sometimes we see the phenomena of pneumosinus dilatans. You see here, the pneumosinus dilatans is an enlargement of the paranasal sinuses, and mostly the sphenoid sinus. It can be also the ethmoid sinus. The treatment for meningiomas nowadays, the first line will be surgery, resect the tumor. Can be surgery plus radiation therapy, namely stereotactic radiosurgery and fractionated stereotactic radiotherapy. Can be only SRS or FSR, and it can be also careful observation. The clinical factors affecting the treatment of choice will be the patient's age, the tumor size, mass effect, neurological status, cerebral edema, patient's comorbidities, and can the surgeon achieve complete resection. Now I'm going to speak about olfactory groove meningiomas and planum sphenoidale meningiomas. This tumor can reach very large size. They can enlarge very slowly, can be even 1 millimeter, 2 millimeter in 1 year, and they can become very large until the patient presents with symptoms or neurological deficit, as you see here. The olfactory groove meningioma arises from the cribriform plate, and the planum sphenoidale meningioma is from the planum sphenoidale. When this tumor reaches a large size, they can reach the optic apparatus. And what differentiates them from tuberculum cellar meningioma is that olfactory groove or planum sphenoidale meningioma displays the optic nerve and chiasm inferiorly rather than superiorly, like in tuberculum cellar meningioma. This is a table that says where is the location of the tumor, olfactory groove in differentiation in tuberculum cellar meningioma, the blood supply, and the location of the olfactory nerves and the optic nerve, as I told you. The clinical presentation, namely personality changes if the tumor becomes large, headaches, seizure, visual deficit also if the tumor becomes large, anosmia, and sometimes the patient will present with Foster-Kennedy syndrome, which means unilateral optic atrophy and contralateral papilledema, the mass effect. Do you see the slide now? Okay. The surgical approaches for this tumor is the subfrontal approach, the bifrontal craniotomy, can be the subfrontal unilateral, can be the pterional transsylvian, and sometimes for the sake of the surgeon to get very low, you can do orbital osteotomy in both approaches, namely taking the orbital rim to enhance the skull-base approach and to go very low and give you a very good angle of attack for high-riding tumor. The surgical steps, namely positioning, neuronavigation, we use currently a machine, it's like a GPS that shows us where are we traveling in the brain or outside the brain in real time. It's really helpful in skull-base surgery to get the anatomy very well and to see the tumor in related to the neurovascular structures. We do the craniotomy, Orbital rim osteotomy if needed. We should tailor the approach for the specific patient. We do extradural drilling in pterional approach. We drill the sphenoid ridge, the greater wing and the lesser wing, the orbital roof, unroof the superior orbital fissure and get as low as possible and reach the meningo-orbital band. Dual opening in pterional will be reflecting in a semicircular fashion to the base. In subfrontal approach, in the bifrontal approach, we use a parallel cut to the orbital roof and we ligate the superior sagittal sinus and cut it all the way to the falx until we free it inferiorly. In pterional approach, describing by Yashergil, we split the sylvian fissure and get inside medially and reach the optic nerve, ICA and ACAs and the third nerve very early in the surgery. In subfrontal approach, we reach this neurovascular structure very late. Then we do tumor devascularization and disattachment. We coagulate the insertion of the tumor so the tumor will be less bloody during the debulking. Then we debulk the core of the tumor by the CUSA. The CUSA is a cavitron ultrasonic surgical aspirator. The subfrontal approach provides good view of both sides of the tumor, while the pterional sometimes is difficult to view the contralateral side. Then we do the microdissection using the operating microscope. I use the operating microscope after I open the dura. And you use it with high magnification and high lightening and separating the tumor from the brain and the neurovascular structure. And in the end, we should reconstruct. In subfrontal, we can use a large vascularized pericranial flap. If we open the skull base, enter the paranasal sinuses. In pterional, we have only a small flap. This is an example of patient that I had operated upon, olfactory groove meningioma. This patient, this lady, presented with personality changes, behavior disinhibition. The children say that we don't have the same mother that we used to have, and I operate on her more than 1 year ago, combined pterional and subfrontal approach. All the tumor is out and she's doing very well. This is another example of large planum sphenoidal meningioma. This patient was a young patient that present actually with left eye blindness for 3 weeks and personality changes, and I operate on him and he's doing well. He start to see something after the operation, and we will see afterwards what will happen with him. He's doing very well. I will speak now about suprasellar meningiomas. Do you see the change?
Yes.
Yes. Suprasellar meningiomas are tuberculum sellar meningiomas and diaphragmatic sellar meningiomas. The differential diagnosis, namely pituitary adenoma and craniopharyngioma. You see here the tuberculum sellar meningioma. You can see that the tumor is separated from the pituitary gland. You see here the pituitary gland. Yeah. This is the tumor. You see very nicely the border between the tumor and the gland. In adenoma, you don't see any border. The tumor is expanding the sella turcica here, and you cannot differentiate the gland from the tumor. You see the homogeneous enhancement.
Yes.
And in pituitary adenoma, you see heterogeneous enhancement. In both tumor, you see compression of the optic apparatus. Here, you see the optic nerve, the right optic nerve, and here the left optic nerve, and here you see the chiasm. Suprasellar meningiomas arise over the tuberculum sella and diaphragm and displace the optic nerve and chiasm superiorly rather than inferiorly as in large olfactory groove meningiomas. Here you see the difference. Here the tuberculum sella compress the nerve upward, and here a large olfactory groove meningioma compress the nerve. You see here the nerve, I pointed inferiorly. Suprasellar meningiomas are the most common tumor that cause visual deterioration. In the literature, it says it's between 56 to 77% will present with visual deterioration. It can be unilateral, bilateral, visual acuity deficit, visual field deficit, optic atrophy, headaches, seizures, and some may present with endocrine deficit, namely the stock effect, cause hyperprolactinemia, and it can reduce the libido and make changes in the menses. It can cause sometimes diabetes insipidus. The surgical approaches is basically the pterional transsylvian approach or the subfrontal unilateral approach to attack this area. In large tumors, some surgeon will go subfrontal approach bilaterally, and as I told you before, the surgeon can do orbital osteotomy to enhance the skull-base approach. In the recent years, the skull-base surgery approaches were developed, and the Cranio-Orbitozuqomatic approach was developed. Namely, it's the frontotemporal craniotomy plus the orbitozuqomatic osteotomy. This approach provides wide expanded exposure and multi-directional access to the anterior cranial fossa, middle cranial fossa, and it opens a window to the upper third of the clivus. As I told you, it takes the surgeon very low below the brain. We use minimal retraction, and it's very good for high-riding tumor. It gives a good angle of attack. At the end of the reconstruction, it prevents orbital reconstruction and enophthalmos when the eye is going backward. The two key players of the Cranio-Orbitozuqomatic approach are the keyhole of McCarthy and the anterolateral part of the inferior orbital fissure. Here we see a left side of illustration of the cranium, and here we see an AP that here is lateral and here is medial. And this is a one-piece orbitozuqomatic approach. McCarthy barrel is here. You see it here. The anterolateral part of the inferior orbital fissure is here. And you do a frontotemporal craniotomy all the way down to the orbital rim. Sometimes you use here the osteotome. And then you cut with a craniotome from the McCarthy keyhole and connect to the anterolateral part of the inferior orbital fissure. And then make a cut here in the zygoma body just above the zygomatico-fascial foramen, not to enter the maxillary sinus, and then in the posterior part of the root of the zygoma. And the last cut will be take the osteotome from the McCarthy keyhole, recognize the lateral part of the orbital roof, and go vertically from lateral to medial, and cut the orbital rift. And then we just elevate the bone flap, and it flicked off and easily break in this place, and you expose the dura. This is an example of two pieces orbitozuqomatic approach. It means, first of all, you do a regular frontotemporal craniotomy. And then, once you elevate the bone flap, in a second piece, you take all the orbital roof with the zygoma, with this cut, almost the same cuts as I illustrated before. Later on, there was a modification of the Cranio-Orbitozuqomatic approach, namely the fronto-orbital craniotomy. Instead of taking all the zygoma with the orbit, you can take only the orbit, like here, making the cut here below the frontozygomatic suture, connect to McCarthy keyhole, and do the same craniotomy. And you taking only the orbital roof, you see here the periorbit, leaving the zygoma in place. And this was the group from the BNI that told us about the supraorbital and the subtemporal approach using this modification, but with two pieces, as I told you before. This is a cadaveric dissection that I have made during my fellowship. This is the right side. You see here the temporalis muscle. We see here the fascia, the outer layer. We see here the cut of the interfascial dissection to keep the frontotemporal branch of the fascial nerve intact. We see after the interfascial dissection, we see the inner layer of the temporalis muscle. Here, the orbital rim, the periorbit that we separate from the orbital roof and the lateral wall, and the zygoma. Here you can see the McCarthy keyhole, and here you can see the route to the inferior orbital fissure that I use it usually and identified it by Penfield 4. This is the McCarthy keyhole. What is the McCarthy keyhole? The McCarthy keyhole is a bare hole that identifies in the center the lateral part of the orbital roof, above it the frontal lobe dura, and below it the periorbit. Here you see the frontozygomatic suture, and here you see the superior temporal line. Usually, the center of this barrel will be 5 millimeters posterior to the frontozygomatic suture and 7 millimeters superior to it. Here is after I turned frontotemporal craniotomy, and we do the orbitozygomatic osteotomy, cadaveric dissection. You see here the periorbit, the frontal lobe dura, the temporal lobe dura, the temporalis muscle. Here on the left side, a piece of the orbital roof, a lateral wall of the orbit, and the zygoma. And here it says zoom in on the cadaveric dissection on the right side. After drilling the sphenoid ridge, we reach the lateral portion of the superior orbital fissure and the meningo-orbital band here, actually containing the meningo-orbital artery. So in surgery, here you see the route to the anterior clinoid process. In surgery, to reach the anterior clinoid process extradurally, one should coagulate here and cut it in the lateral portion of the superior fissure so we can retract posteriorly the temporal pole of the temporal lobe to reach the anterior clinoid process. The surgical steps is positioning, nerve navigation, craniotomy, orbital rim osteotomy if needed, pterional, as we said before, drilling the sphenoid ridge, reaching the meningo-orbital band, and in subfrontal approach, mostly unilateral in these cases, you open parallel to the orbital roof. And as I said before, the advantage of the pterional after splitting the Sylvian fissure that you can reach the critical neurovascular structure very early in surgery, identify them, allocate them, preserve them, and take out the tumor. In subfrontal approach, you may reach this neurovascular structure later on. This is an intraoperative photograph on a patient that I have operated on, showing the splitting of the Sylvian fissure on the right side. This is the temporal lobe. This is the frontal lobe on the right side. Using a microsurgical technique, we split this Sylvian fissure and recognize and identify the MCA candelabra, and in this case, this is the MCA M1 that you can see. And after splitting the fissure, one can expose the tuberculum sella, and you see here very nicely the optic nerve on the right side, the meningioma just below it, coming from the tuberculum sella. It's asymmetric tuberculum sella meningioma, and compressing the nerve superiorly. Here you see the supraclinoid segment of the internal carotid artery and the posterior communicating artery. And this is the photograph after taking out all the tumor. This patient, this is the imaging, preoperative and postoperative, and she's doing very well. This is another case of tuberculum sella meningioma that presented with blind eye on the right side, as you see here. And after surgery, I think it's 3 months after surgery, you see all the tumor is out, and there is a little improvement on the right eye. Practically no improvement, but a little one. Namely, we do this surgery to try and to prevent visual deficit on the contralateral side, and at least keep the same vision on the ipsilateral side and even improve it. Recently, during the last decade, endoscopic endonasal transsphenoidal surgery is being currently increasingly utilized in the management of midline skull-based tumors, can be pituitary adenomas. You see here the endoscope here. You see here the sphenoid sinus, the sella turcica, and with this endonasal endoscopic approach, we actually use the natural corridors to take us through the sphenoid sinus to the sella turcica, the planum sphenoidale, the cribriform plate here. And actually, we can attack all the anterior skull-based meningiomas from within the nose using the endoscope. These cases are suited for midline skull-based tumor, not huge one, small one, in the center. This is an intraoperative photograph taken from our paper that we published in 2014. You can see the endonasal endoscopic surgical anatomy from within the sphenoid sinus. The endoscope is in the sphenoid sinus, give us this beautiful picture. You see here the planum sphenoidale, the sella turcica, the clivus, the paraclival ICA, the intracavernous ICA, the optic canal. You see here the medial wall of the optic canal, and here the tuberculum sella. So here you can see that you can really come below the brain using the natural corridors and using the advantage of skull-base surgery without any retraction for the brain. This is a cadaveric dissection that we have done in the skull-base lab at Cornell University, New York Presbyterian Hospital. My colleague, Dr. Danilo Silva, and myself, that we contribute equally to this manuscript, we did together this dissection. And you can see very beautifully the intradural anatomy. After taking out the bone of the clivus here, the sella turcica here, the tuberculum sella, and the planus sphenoidale, and opening the dura, you see here the pituitary gland with the dura. You see here the basilar artery. You see the optic chiasm, optic nerves, and this is a very good approach to midline skull-base tumor. I would say nowadays the endoscopic endonasal transsphenoidal approach will be the workhorse of pituitary surgery. Pituitary adenoma. And my mentor also say, once you do lots of pituitary adenoma surgery, you can start to do tuberculum sella meningioma surgery. Here another photograph, Transtuberculum Transplanum approach. You see here the pituitary gland, you see the pituitary stalk, you see here the superior epiphyseal artery that coming from the ICA supplying the optic chiasm and the optic stalk, optic nerve, frontal lobe, and the ACAs. This is a picture from a different paper that we published with the Cornell group after taking out from within the sphenoid sinus tuberculum sella meningioma. Suprasellar meningiomas often invade the optic canals, usually at the inferior medial portion. And it's sometimes very hard to reach this portion through a transcranial approach because the optic nerve is just in your way. Unroof the optic canal invaded by the tumor transcranially. We unroof the superior wall of the canal, and endonasally, we unroof the medial portion or the inferior medial portion of the canal. We do this to reach gross total resection, to decompress the optic nerve, and to prevent tumor recurrence. This is photographs from our paper, was published in Neurosurgery in 2012. You can see here tuberculum sella meningioma, and you see very nicely here that the meningioma invade the optic canal, and it usually invades the optic canal in the inferior medial portion of the optic canal. It's very difficult to reach it to transcranial craniotomy, and you can see here very nicely that from endoscopic endonasal transsphenoidal approach, you can very nicely reach this portion of tumor because the medial wall of the canal is just there. You open the dura and take out the tumor without any retraction. This is a cadaveric dissection from within the sphenoid sinus that was made by my colleague, Dr. Lee, who was a fellow from Singapore, that show us the feasibility to unroof and decompress the optic nerve from within the sphenoid sinus. You see very nicely the optic nerve in the optic canal, the ophthalmic artery running here. You see here the optic strut is actually the inferior portion of the optic canal and separated from the superior orbital fissure. There are still differing views regarding the technique of endoscopic endonasal optic canal decompression in patients with suprasellar meningiomas. There are people that do it from lateral to medial, and we publish about doing this from medial to lateral. Exploration and decompression of the optic canal has not been routinely recommended. There are people that do lots of this surgery, and there is a group that is not recommend opening the canal from within the sphenoid sinus. And we say, if you have the experience and the expertise, you can do this. This is a video that I'm going to show you. This is a surgery that was done by Professor Theodore Schwartz from Cornell, New York Presbyterian Hospital. Was my mentor during the fellowship in endoscopic surgery. And you can see here the video taking out the floor of the cellar with a kerrison, taking out after opening the dura the core of the tumor with the Hellman, and then using microdissection and separate the arachnoid and exposing the ACAs that you see here. Continuing dissecting the tumor, you see here, with the scissors, micro scissors, and then in a late fashion, making the optic canal decompression here with a small kerrison, you see here. This is the optic canal. This is the optic nerve entering the canal, separating the tumor from the optic apparatus. This is the optic chiasm, the ACA, the ACOM, the ophthalmic artery is here. You see all the tumor is out, and then reconstruction with fat pad, inlay, put a fascia lata onlay, and Medpor, the gasket seal. You see here to prevent CSF leak, and then put a nasoseptal flap, Duraseal, and Surgiflow. After I show you late decompression of the optic nerve, after taking out most of the core of the tumor, we show also in this paper that one can do an early optic canal decompression, because nowadays more and more skull-based surgeons prefer to decompress the optic canal first in surgery, because once you manipulate the tumor and you have the optic nerve tethered in the optic canal, you can cause by the manipulation an injury to the optic nerve. So more and more groups prefer to decompress the nerve first and then attack the tumor. So we show in a different case that you can do optic canal decompression from within the sphenoid sinus early in surgery. You see here the dura of the tuberculum cella, and here after taking the medial wall of the optic canal, you see the optic nerve sheath. We also created a simple algorithm to manage the optic canal during endonasal surgery involving late decompression of the canal. Basically, we suggest to attack tuberculum cellar meningioma that are in the midline, no more than 1 centimeter lateral to the ICA or lateral to the lamina papyracea. And then, if there is no tumor in the canal, you just need to inspect and look around the corner with a 45-degree scope to see if there is a tumor inside. If there is a tumor inside, open the canal. If you see in the MRI that there is a tumor in the medial part of the optic canal, open the canal. And if you see in the MRI that there is a tumor in the lateral part of the optic canal, If it's gross total resection is the goal of surgery, go for craniotomy. You cannot reach it by endoscopic endonasal approach. But if you need only to decompress the nerve, knowing that it will be subtotal resection, you can open the canal. Now I'm going to speak about sphenoid wing meningiomas. Did you see the change?
Yes, we do.
Sphenoid wing meningiomas are the most common skull-based meningiomas. Almost 20% of all intracranial meningiomas. The insertion can be the lesser or the greater wing, and this tumor may spread to the dura and bone and multi-compartmental, like frontal area, temporal area, orbit, superior orbital fissure, lateral wall of the cavernous sinus, cavernous sinus, infratemporal foci. They can be very invasive. There are numerous classifications of sphenoid wing meningioma. The first one was by Cushing, the inner third, the medial sphenoid wing meningioma, or spheno-cavernous meningioma, middle third, and pterional. Pterional is outer third. There is also the classification by Brocchi and Bonal that divide for 5 groups. There is a unique subtypes of sphenoid wing meningiomas is the Spheno-Orbital meningiomas. It means that it's actually a sphenoid wing meningioma that invade the orbit and compress the periorbit and the optic nerve. And this tumor tend this tumor can cause and invade all the skull base area in the vicinity of the spheno-orbital region. Another type or subtypes of sphenoid wing meningioma is the anterior clinoidal meningiomas that we will speak later on. The clinical presentation will be diplopia, third nerve palsy, exophthalmos, visual deficit, headaches, seizures, and increased ICP. The surgical approach will be anterolateral, pterional, or Cranio-Orbitozuqomatic that I described before. Can be intradural Transylvian approach, and it can be extradural approach to the cavernous sinus that was described by the pioneering work of Dr. Vinko Dolenc. It's called the Dolenc technique. The Dolenc technique, it's namely the extradural clinoidectomy, extradural removal of the optic strut, extradural unroofing of the optic canal, and early ICA optic nerve and third nerve identification. This is a cadaveric photograph from a paper that we published. The dissection was made by my dear mentor, Dr. Sergei Spector. You can see here the surgical anatomy after extradural clinoidectomy. You see here the clinoidal segment of the ICA following resection of the anterior clinoid process that was just here, in between the distal dural ring that is here and the proximal dural ring that is here. The proximal ring is the continuity of the lateral wall of the cavernous sinus, the inner layer, and the distal ring here is in continuity of the lateral wall of the cavernous sinus, the outer layer. The distal ring here connects the optic nerve sheath to the carotid, and the proximal ring connects the oculomotor nerve here to the carotid artery. So following extradural clinoidectomy, we reach this cornerstone of the oculomotor nerve running en route from the lateral wall of the cavernous sinus to the superior orbital fissure, the clinoidal segment of the ICA, and the optic nerve and optic nerve sheath. This is a cadaveric dissection that I have done during my fellowship. This is the inner layer of the cavernous sinus. After peeling off the outer layer of the lateral wall of the cavernous sinus, we expose this layer. You can see the oculomotor nerve, the trochlear nerve, the ICA, the trigeminal first branch, the trigeminal second one that is exiting through the foramen rotundum, and the V3 that exiting from the foramen ovale. And you see we can reach this inner layer following peeling the outer layer of the lateral wall of the cavernous sinus. And during surgery, whenever we have sphenoid, medial sphenoid wing cavernoma, meningioma, sorry, or spheno-cavernous meningioma, we can peel from anterior to posterior, from medial to lateral, the tumor extradurally, and we take also the outer layer and reaching the inner layer of the cavernous sinus. Today, we are not operating on meningioma inside the cavernous sinus, only taking out from the lateral wall, because the functional outcome of the patient are very bad. Here you see the cadaveric dissection that I have done on the posterior part of the cavernous sinus. You see here the Gazerian ganglion in the Maker's cave, and you see it's an interdural component of this V1, V2, and V3. After opening the Parkinson triangle, you see here, between the 4th and the 5-1, you identify the ICA and the abducens, the 6th cranial nerve that is running medial to V1 and lateral to the ICA. This is some example of patient that I have operated on. This is an outer third sphenoid ridge meningioma or pterional meningioma. This is a middle third. You see here in the cerebral edema. So we treat her and she's doing well. You see here. And this is a spheno-cavernous meningioma or medial sphenoid wing meningioma that was taken by using this technique. And this is another one. You see here the medial sphenoid wing meningioma or the spheno-cavernous meningioma can reach the anterior clinoid process here, but it's usually lateral to it and not encasing. The anterior clinoid process is not centered in the middle of the tumor. Now I would like to speak about spheno-orbital meningiomas that are subtypes of sphenoid wing meningiomas. Did you see the change? Spheno-orbital meningiomas can be multi-compartmental, and it can cause mainly exophthalmos, visual deficit, because the invasion of the orbit. The surgical technique is quite the same as the sphenoid wing meningioma, the frontotemporal craniotomy with or without orbitozygomatic osteotomy, and the neurosurgeon can try to take all the tumor from the transcranial approach from above. There is an alternate strategy to combine to the lateral approach, the transcranial approach, an endoscopic endonasal approach to a part of the tumor that invade the paranasal sinuses, the infratemporal fossa, that can be in spheno-orbital meningiomas. And you can see this table shows us the percentage of components of tumor that invade the sphenoid sinus, the ethmoid sinus, the infratemporal fossa, the pterygopalatine fossa, and it's between 4 to 12% of the cases that this tumor penetrates to the paranasal or infratemporal fossa. This table shows us that even today, gross total resection can be very difficult. You see here in yellow a low percentage of gross total resection nowadays using transcranial approach, because this tumor is very invasive and it's very hard to take all of it. So we have to make all our efforts to use our new technology to take out all the tumor. And as I told you before, one of the new technology is the endoscopic endonasal surgery. So if you have a spheno-orbital meningioma that invade the sphenoid sinus, like you see here in this intraoperative photograph, or you see here a tumor extending from the pterygopalatine fossa, you can combine the transcranial approach with the endoscopic endonasal approach. It can be in the same sitting or in different surgeries. So basically, the endoscopic approach can complement the transcranial approach to reach gross total resection in one setting. And now I want to end this session and to speak about the anterior clinoidal meningiomas. And while anterior clinoid process origin may be clearly seen in small clinoidal meningiomas, in large one, it can involve relatively large areas of the anterior skull base, and there are some problems with the definition of this kind of tumors. There are some series in the literature that put the anterior clinoidal meningioma with medial sphenoid wing meningioma, and we think that this is wrong because anterior clinoidal meningiomas are unique. And our definition, and we believe this is the correct definition, the tumor in these cases is centered around the anterior clinoid process, which is usually hyperostotic. You see here an example of small anterior clinoidal meningioma, and you see here that the tumor is encasing the anterior clinoid process. You see a large one that encases the anterior clinoid process. To compare, you can see the medial sphenoid wing meningioma. The anterior clinoid process here is not the center of the tumor. And the clinical pearl is in anterior clinoidal meningiomas, the chances that the optic canal is involved is much higher than medial sphenoid wing meningioma. So most probably in this tumor, you should deal with the optic nerve more often than with this tumor. The clinical presentation is Visual impairment, the first sign, can be cognitive deficit, because this tumor can be very large and grow superiorly, subfrontally, and cause these changes. The surgical approach are the same as sphenoid wing meningioma. You may use the pterional or TOZ, the intradural transceval approach, or the extradural Dolenz approach. This is an example that I showed you before, splitting the fissure and just reaching this area and taking the tumor. And this is an extradural approach that we published, going subfrontally, recognizing the falciform ligament, the superior wall of the optic canal, doing unroofing of the optic canal and extradural clinoidectomy. After we do extradural clinoidectomy, we reach this cornerstone. This cornerstone, you see here, is the optic nerve in the canal, the ICA, the clinoidal segment, and the oculomotor nerve en route to the superior orbital fissure. And you see here the advantage of this approach. This cornerstone is not violated by the intradural tumor. You see here the tumor is violating the anatomy. Here is preserved anatomy, so you can use this cornerstone as a start of a roadmap and take the tumor in a bidirectional fashion. That's it. Thank you very much. Thank you for the invitation. Thank you. Hi there. Are you tired? I cannot hear you. Hello? Do you hear me?
Hello.
Yes.
I can hear you, Lee. Thank you very much for that presentation. It was wonderful. I learned so much from that. I think Dr. Bennett is muted at the moment.
Yeah, I can tell. Dr. Bennett, we cannot hear you.
Oh. Oh, well. Perhaps we can ask some questions. May I ask a question, Dr. Attia?
Yes.
Thank you. I'd like to ask a question regarding a video I watched before your lecture regarding medial sphenoid wing meningiomas, and they were showing that before the operation there was a lumbar drain that was used to decrease the intracranial tension. Is that something you would do commonly?
Okay. Yeah, I would say this. A lumbar drainage is a tool to lax the brain, and you may use it when you deal with large tumors. And you may do this. Sometimes we do this with olfactory groove meningiomas, large one, when you want to go subfrontally and you want the brain to be lax. There are several ways to lax the brain. I personally, in sphenoid wing meningiomas, prefer not to insert a lumbar drain. Usually what I am doing, I'm splitting the sylvian fissure. And once you split the sylvian fissure, you reach the CSF and you wait and let the CSF drain, so the brain will become lax, because, you know, there are some problems with lumbar drain. Sometimes there are reported cases that because of the draining of the CSF, the brain suffer from CSF hypovolemia. So because of the positioning, we found some remote hemorrhages in the cerebellum. And it's described, you have some remote hemorrhages in the cerebellum after pterional approach, and people believe it's because CSF hypovolemia, and lumbar drain definitely will cause CSF hypovolemia. And I can tell you, during my fellowship, I did lots of aneurysm surgery, intracranial aneurysm surgery. And once you have ruptured aneurysm, sometimes we use the lumbar drain because the brain is very angry, very swollen, and the lumbar draining, it's very helpful to lax the brain. And we found some remote hemorrhages in the cerebellum. So I prefer not to use it, but one can use it, definitely.
I see. And in this case where you are just looking at the drainage and deciding your strategy, would you be working closely with the neurointerventional radiologists?
When? I'm sorry?
Are you working with neurointerventional radiologists in this process? Yeah.
I tell you, lumbar drain, you don't need interventional neuroradiology, but we used to work with the interventional neuroradiologists. Sometimes we have meningiomas that have a huge blood supply from the external carotid artery. So to prevent bloody surgery, you may embolize the branches that supply the tumor from the external carotid artery, not the internal. The internal, you may cause problems. Yes.
I see. Thank you very much. Before we continue with other questions, I would like to introduce Dr. Alexander Arenas from Los Angeles.
Hi.
Hello all. Nice to meet you. I'm sorry for the tardiness. Dr. Attia, I find your lecture very interesting, and I learned a lot from you.
Thank you
so much for that.
Thank you, sir.
Wonderful.
My privilege. Thank you.
We also have a Twitter question that is regarding the ratio of women to men, of women to men being around 2 to 1, and I was learning that the cause is for meningiomas is considered to be a deletion of chromosome 21, or the long arm of chromosome 21, if I'm saying it right. But I'd like to learn more about
not 21. It's
22. 22. Thank you very much.
Absolutely. We find in 50% of the cases of the sporadic intracranial meningioma or spinal meningioma, a lesion of the 22nd chromosome in the large allele, in the large arm. So definitely in sporadic one. And as I told you, in familial, in neurofibromatosis type 2, the lesion is the neurofibromatosis gene that is injured. Definitely.
I see. May I might take this time to turn the question over to Dr. Lewis and ask if he has a question regarding your presentation.
Yes, please.
Okay, congratulations, Dr. Atta, Moshe. A very nice presentation.
Thank you, sir.
I am neurointerventional radiologist.
Yeah.
I agree with you. With sometimes you not need the pre-surgical embolization because you are the new techniques to remove the meningioma. My question is, when do you believe is necessary the embolization? In the case with the special localization, for example, when the meningioma involving the middle cerebral artery, or when a meningioma involving the ethmoidal arteries, every time is the participation of vascularization is now with external carotid artery is external and internal carotid artery with the ethmoidal artery of ophthalmic artery or the middle branch of the cerebral artery. And no, just a minute. Some 3 questions, and then you respond. The second, how many blood or bags of blood you utilize and you need in the surgery is in the complex meningioma. And finally, classical embolization of the meningioma is the particles, is the PVA particles. You use the PVA polyvinyl alcohol particles. But now I have a new product, is the onyx. And this technique with the onyx is very successful because it's possible to remove in block. It's possible to remove the same of the AVM, these meningiomas. If you want, and Bennett, John Bennett, and the people, it's possible to present one small case with very, very difficult technique on embolization and totally remove with this surgery. But finally, congratulations with excellent work.
Thank you, sir. So regarding the meningioma embolization, as I told you before, sometimes we use embolization for very vascularized meningioma, very large one. But we will use the embolization only, and just only, if we have the external carotid artery supplying the meninges, very meningeal supply of the meningioma, because the internal carotid artery is impossible, as you say, because you can cause harm. The ethmoidal artery coming from the ophthalmic artery, you should be very, very cautious. You can lose the vision. So, honestly speaking, we use very rarely embolization nowadays. Very rarely. As you said, in the new techniques, with the bipolar, with the hemostats that we have, the gel foam, the Spongistan, Surgiflow, you name it, we actually attack, and really going with the principles of skull-base surgery, attack first the insertion of the tumor. Just go there with the bipolar, disattach the tumor from the skull base, from the insertion of the tumor, coagulate the blood supply of the tumor, and then start the debulking so the tumor will be much less bloody. And about the onyx, I agree. Our endovascular guy is using only onyx nowadays, I believe. Maybe I am mistaken. But most of the I know that he's using the onyx. It's like a cream of you know, it's a cream, very nice to handle it. But as I told you, I don't really have the experience with embolization. We just do not do this on a regular basis. Thank you.
Thank you. And I wonder if there are any other questions from Dr. Alexander Arianes. Are there any questions?
Yes, I have a question. In your experience, what is the long-term prognosis for all these different procedures that you're practicing with your patients?
I'm sorry, I cannot hear you.
I'm sorry, can you hear me now?
Yes, please.
Oh, I was saying, in your experience with all these different procedures that you're practicing, what is the long-term prognosis of your patients? What is the evidence?
Yeah, absolutely. The long-term prognosis of meningioma patients is perfect. Once you do the surgery, you take out all the tumor, and you preserve the neurovascular structures, and you preserve the functional outcome, the patient will do great. Because we follow the patient. One of the problems is recurrence. Meningiomas, especially of the skull base, can recur. We follow the patient for the rest of their life. Most of the meningioma will recur in the first 5 years. It can be also after 10 years. So I would say during the first 5 years, we will do every year an MRI on the patient to see if there is a small recurrence. And then I will change it to every 18 months. And then after 10 years, every 2 years. So the prognosis is very, very good. Nowadays, we have to take into account that we try in the surgery to take out all the tumor, but if we cannot take all the tumor and there is a small piece that is very adhesive to very important neurovascular structure, I leave it, because now we have the stereotactic radiosurgery, the fractionated stereotactic radiotherapy. So we can follow the patient with a small residual tumor. If it's not growing, I will not do anything. And if the tumor is growing, we will give him radiosurgery. And we know nowadays that stereotactic radiosurgery have very good results to control meningiomas. More than 90% of meningiomas, small meningiomas, after stereotactic radiosurgery, you get very good control and the tumor will not grow anymore. So the neurosurgeon nowadays should keep in his mind that you should do the surgery and you take as much as you can, but you can definitely leave small piece of tumor behind not to get a bad functional outcome because of this new technique.
Excuse me, sorry to interrupt you. It's a wonderful and very interesting answer. And I'd like to ask Dr. Lewis to chime in regarding the endovascular techniques and regarding meningiomas. How would you handle a meningioma from a neurointerventional technique?
Okay. Okay. If you want, I present you one case, difficult case to discuss with Dr. Attia. I think.
I'm sorry, my name.
Sorry, Attia. Yes.
No, it's okay.
No. Okay. I'm sorry. And I think it's a very difficult case because every meningioma is not the same. It's depending of the histological meningioma. This is a young man, about 27, 28-year-old. This is the magnetic resonance in June 2004. In June, you have the meningioma involving a small part of the middle cerebral artery, and the coronal view. You have the meningioma involving the middle cerebral artery and involving the canal optic and the parasellar and paracavernous portion. Okay, have edema. You have this patient 9 previous surgery, 9 times. You have the cranectomy here. And the patient is well, don't only have a diplopia, pain, frontal syndrome, epilepsy, but not have the very neurological deficit. In this situation, I wait, and 6 months later, about in October, November, the meningioma grows very fast. You are this is the volume of the meningioma, and the most important, you are the involving totally the middle cerebral artery. You have the edema, and a rupture of the base of the skull, the temporal lobe, it's the rupture. And this situation, you are a second meningioma here, small, and the situation have the patient have the very, very, very complex symptom. And this is the angiography before embolization. This is left carotid internal and external carotid artery in AP view. a medium phase, and late phase, you are the collateral circulation of the leptomeningeal and collateral circulation in the middle cerebral artery. Okay, the meningioma have the vascularization is with the middle cerebral artery and ethmoidal artery. Let's see here. And you are the collateral circulation. This important point, you are the anterior choroidal artery is here. And you need to preserve this artery. It's possible to close this meningioma because the middle cerebral artery is functional anatomical with the anastomosis, leptomeningeal anastomosis. This is the lateral view. You see.
Sorry, Dr. Lewis, we cannot see your screen.
Ah.
I wonder if you can share it. You can press the screen share.
¿Qué tengo que hacer?
The screen share on the left side. If you put your mouse on the left to the green button, I think you can share your screen.
Just a minute. Just a minute.
I have a better suggestion. Maybe you will present in a different session.
Okay, I think it's okay. Okay.
Yeah.
Sounds good.
So thank you guys. Thank you for the opportunity. I think it's a great tool. I was happy to present this presentation, and I will continue the presentation later on with the posterior fossa meningioma.
Thank you so much. We really enjoyed your presentation.
Thank you, and we will meet you later on. Thank you.
Thank you. We're hoping to introduce and bring into your friends from Cornell and Singapore into one hangout and get everyone together. And we'd like to express our extreme appreciation also from Dr. Bennett. So if you'd like to hold on, we're just going to finish the session.
Thank you. Thank you.
One moment.